So our last speaker for the morning session here, we have Alaa El Danab. She's a registered dietitian at Princess Margaret Hospital. She completed her bachelor's degree in nutrition and food from Ryerson University in 2015. She later went on to complete her graduate studies at McGill University in 2017. And Alaa currently practices in the field of oncology at the Princess Margaret Cancer Center and is also part of a research study looking at the effects of prehabilitation in breast cancer patients undergoing neoadjuvant chemotherapy. So we'll welcome her to the stage.
Hi, everyone. Thank you so much for inviting me here today to speak to you about this topic that I am quite passionate about. So before we begin, I have nothing to disclose for this presentation. So when we talk about nutrition and oncology, it's quite a broad field. So really we have prevention, treatment, and survivorship. So the way that I'm going to go through it is, talking about nutrition and prevention quite briefly. The bulk of the presentation will be talking about treatment and then briefly about survivorship. So if we look at nutrition recommendations for cancer prevention, so the Academy of Institute of Cancer Research has sort of laid out 10 recommendations that help with cancer prevention. So a lot of these recommendations are based on lifestyle, right? And a lot of the research has shown that 30 to 50% of cancers can be prevented by lifestyle alone. So as you can see, the first recommendation really is maintaining or achieving this appropriate weight. Weight is something that's very individual, right, for a lot of individuals. But just as important is this whole aspect of physical activity, right? So it's engaging in any type of physical activity within your day or within the week. And lots of research, and I know that a lot of you are probably aware of this, lots of research on plant-based, diets, limiting our consumption of added sugars, limiting our consumption of red meats and alcohol. And really, if you've seen the new Canada's Food Guide, the main recommendation is achieving nutrition through food and not using supplements, as we've seen in the previous presentation, to use the supplements for cancer prevention, right? A lot of the times I have patients that say, oh, I found this supplement online. It said that it prevents, tumor growth and whatnot. And again, it's going back and shifting to, eating whole foods and really enjoying eating through the foods that we are eating. So, and as you can see too, a lot of these recommendations are not just for cancer prevention. It's very similar to other chronic diseases, right? These are recommendations that everyone, even myself, should be striving for. So if we go on and look at nutrition through treatment, and this is where the bulk of my talk is going to discuss. As we know, cancer is one of the leading causes of deaths around the world now. But just as important, right, as physicians, as new technology has evolved, we're treating and we're managing these cancers better to help the outcome for our patients. Something that you'll see that is very common among cancer patients is this whole aspect of unintentional weight loss, right? And so the magnitude of weight loss can differ between an individual depending on the disease and depending on the severity of the disease. So malnutrition is something that as a dietitian, as healthcare professionals, we have to be very cognizant about because it can really negatively impact an individual's treatment through their cancer journey. So as you see, it's estimated that 40 to 80% of individuals experience malnutrition during treatment. Now, the aspect of malnutrition is there's two factors. So it's this physiological consequences that occur from the tumor, these pro-inflammatory cytokines that are produced. They alter the metabolism of carbohydrates, protein, fat, right? It's this catabolic aspect that we see among some of the cancer patients. Sometimes you see patients who are very cachectic looking. But just as important is for us to be able to identify these people so they can receive appropriate nutrition intervention. Because what we've seen is the presence of malnutrition can really limit the response to even the best treatments. So nutrition has to be addressed. Oftentimes, I see patients that have to stop halfway through their treatment because of treatment toxicities. They're just not doing well. And the other aspect are these anti-cancer treatments, right? Chemotherapy, radiation that really cause individuals to feel nauseous and can really exacerbate this issue of malnutrition. So this diagram here sort of illustrates the consequences of malnutrition. So again, this is not just specific to oncology, but it's specific to any individual who presents with malnutrition. As you see, there's muscle wasting that can impair one's mobility, right? Reduced independence. It can really sort of escalate this whole cycle and be very debilitating. And it can also increase the length of stay of individuals in hospital. And it's sort of shown that people stay 3 or more days extra when they are malnourished. So again, something to really think about and something that we have to all work together as a team. So how do we do that? Well, we have 2 screening tools that we use, right? So the CNST, as you see right here, and the Malnutrition Screening tool. Both tools are validated in an oncology population. They're very similar, as you see, very similar questions that are asked between the two. The screening tool is really meant for, our frontline staff, like nurses, to be able to embed these questions within their admission notes, because they're the first point of contact for individuals, right? That they come into the hospital, they ask these 2 simple questions, and then if the individual screens yes for 2 of the questions, so again, we're looking at unintentional weight loss. So if an individual lost some weight, but then regained it back, then you say no. So on admission, the answer would be no. If an individual lost weight, but it was intentional, then again, it would be no. So you're really looking, it's quite specific, right? So have you lost weight in the past 6 months without trying? Unintentional, right? And then have you been eating less than usual for more than a week? Again, 2 simple questions, and lots of research has gone through this. If you go to the Canadian Malnutrition Task Force website, research by Heather Keller, great groundwork that's being done to sort of advocate, to provide more education for all of us in the healthcare field so we can be able to identify those individuals at risk, right? So just to step away from nutrition screening, historically speaking, there was this whole notion of biochemical markers like albumin, pre-albumin, transferrin, retinol binding proteins that individuals would use to sort of screen individuals for nutrition status. We've known that over time with research, we know that albumin is not the best tool to use in order to sort of identify individuals at risk for malnutrition or have some nutrition compromisation, because we know that these serum proteins are affected by other means, and the one simple aspect is this whole aspect of inflammation, right? And these individuals in an acute care setting, this is quite present. So there's no specific biochemical marker, unfortunately, to sort of identify individuals at nutrition risk. Instead, we kind of focus on nutrition-focused findings and physical findings. So we kind of use, as dietitians, we use the subjective global assessment, and this is really a gold standard to sort of diagnose malnutrition. It's very easy. It's embedded within our assessment. So when individuals are screened by the nurses, it sort of triggers this automatic referral, and then as dietitians, we see them, we do our assessment, and this is part of our assessment. So it is completed, ideally, we would like it to be completed within 24 hours, but sometimes that's not possible, and that is okay. And it is, again, it's validated in an oncology setting. So it's quite specific. If we look here, it's kind of small, but we look at weight, within the past 2 weeks, any changes that have gone on. We look at functional status. We look at any factors that affect intake. So impaired swallowing, are they fatigued? Are they nauseous? Is there diarrhea? So all of these things are taken into consideration. We also do a quite comprehensive physical assessment to look at their stores, right? Their temples, under their eyes, their clavicle region, their arms, their legs, any edema present, right? All of that sort of factors in within our assessment. And then we triage. We triage according to whether they are triaged according to an SGA-A, so that would be someone who is well nourished, but just needs some sort of reminders, needs alterations within their diet, or an SGA-B, so someone who is mildly or moderately malnourished. So again, our nutrition intervention would be tailored towards that. And someone who is an SGA-C, so someone who is very severely malnourished, we would tailor our intervention then. So we would really go in depth. So again, this tool doesn't necessarily have to be completed by a dietitian, but over the years, because this is embedded, so at UHN we do embed this within our assessment, that sometimes it is the dietitian that is completing this tool. So how do we sort of embed this into practice? And this is specifically referring to screening. So as I said, it doesn't need to be conducted by a nutrition professional. A lot of the research within the CNST, they found that individuals who weren't trained, so nurses, right? We know that, in a hospital, things get busy. We want something that is realistic and it reflects a real world setting. And this is what that CNST actually is there for. So it doesn't have to be completed by a nutrition professional. It can be done by frontline staff, nurses. So again, we have to sort of develop this referral system. So if they screen yes to 2 of the questions, then yes, they're at nutrition risk. And then that hopefully would trigger an automatic referral. Whether you have an electronic, referral system, then you can embed that in there. And I've been in hospitals where it is embedded and it sort of triggers that automatic referral. Or sometimes, in smaller settings, you can sort of consult with a dietitian, say, hey, this person screened yes, they're at nutrition risk, let's consult the dietitian. If this is something that, you're starting to implement in practice, and this is something that we continue to work with and sort of tailor, for better outcomes, it's best to sort of implement this in a small ward first, see how it goes, collect the data, and then tailor it amongst what is found, and then you can implement it on a larger scale. So again, a lot of great research. If you just go to the Canadian Malnutrition Task Force website, there's great information, and it can sort of support how individuals want to sort of implement this in an acute care setting. So some of the challenges, so switching back, right, nutrition and treatment, some of the challenges that we face when we see, some patients are these treatment-related side effects, right, with the anti-cancer treatments like the chemotherapy and radiation. So anorexia is huge, so that's loss of appetite. That's complete loss of appetite. Fatigue, right? People feel tired. They can't get up. They don't want to prepare meals. They don't have that support. Nausea, that can be mild or it can be quite significant, that it can completely impair one's eating. Certain comorbidities, right? Some people have diabetes that we have to sort of tailor the diet, or chronic kidney disease, where some people have to be on, a low potassium or a low phosphorus diet. Heart failure, maybe they need a low sodium or restricted fluids. And a huge one that I see a lot is prior information to, misinformation on the media. this is huge because it can really, really limit an individual's diet. They hear something and they're like, oh, I heard it from, I don't know, this website, and they told me this, but then you're telling me something else. And so I have to work with them. We often have to work together and develop that trust. And then it makes it easier to make the changes. Any special diets, right? People might be vegan, vegetarian, kosher, halal. So we have to really work within our means. And then intolerances to nutrition support. So some patients where intake can be quite debilitating, some individuals have to go on tube feeds, enteral nutrition or parenteral nutrition. So it's bypassing the GI tract and it's delivering the nutrition through your blood, your veins. So sometimes we have to monitor that and see how individuals are tolerating. So in terms of now nutrition, when we think about rehab and after treatment, same recommendations that we sort of advise in prevention, right? The 10 recommendations, same recommendations. At UHN, the awesome thing is that we do have some support programs after treatment. So we have the head and neck survivorship program. There's a dietitian that sees these patients 3 months after treatment, and she sort of, focuses on how to properly nourish that individual, any lingering side effects that happen, especially in the head and neck population where it is quite significant. We also have the Elixir kitchen. So it is led by a wellness chef and a dietitian where they prepare workshops for individuals to come and sort of cook and prepare meals. But all these workshops are tailored, and they can be tailored depending to some of the treatment-related side effects. So there are workshops for fatigue, let's say, right? So they'll prepare stuff for fatigue and have individuals cooking with them. Or they'll have, workshops for taste changes. So the wellness chef will prepare meals and recipes and sort of tailor that with the participants that are present in the room. So I did leave the website. I often refer my patients to the website because they have all the recipes there. Really great resources, so something to really look into. And so if, this is important, when to refer individuals to a dietitian. So patients who are receiving radiation to the whole body, right? Because some of the treatment-related side effects will be quite daunting for them. Especially radiation to the head and neck. So with head and neck cancers, individuals might have impaired swallowing, so we have to tailor the diet accordingly. Some individuals will also have a feeding tube to deliver the nutrition in. So again, there we would get heavily involved. Individuals, again, who have lost significant amount of weight, so greater than 10%, and again, it's unintentional weight loss. And two, individuals who have really significant treatment-related side effects like the nausea, the diarrhea, taste changes, fatigue. Those are all things that we work with. And then also individuals who are following any specific special diet. So in summary, nutrition does play a really vital role for individuals, for everyone. And we all have, a place to sort of work with the individual and screen individuals and refer. So screening requires intercollaboration with other professions, right? We can't do this alone. We need the support from physicians. We need the support from allied health staff, nursing, unit clerks, other healthcare members. And the more proactive we are, the better we can actually screen individuals and then have that referral in place so that they can see the dietitian, a nutrition professional, and seek that support that they actually need. So that is that.
Great, thank you. So we'll take some questions if there are any.
Yeah. So the difference between a dietitian and a nutritionist. So as dietitians, we go through a rigorous training program. So we go through, we get our bachelor's degree, and then we have to go through a master's or internship screen. We are regulated healthcare professionals, unlike nutritionists, where they are not regulated. They can't necessarily practice in a healthcare setting. And it's not to discredit any, there are good nutritionists out there, but we have the proper training and sort of, a little bit of that complexity that we're able to sort of work with, right? I mean, it could be basic nutrition education, right? That I can do, that someone else can do, but then it can get quite complicated to that nutrition support. So things like TPN or the enteral nutrition, where it does need that, those little extra expertise and skills. Yeah. Mm-hmm. Yeah. 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 So the gentleman in the back was saying that given that diet is very important within prevention, we should be focusing a lot of our efforts in that area. And you're absolutely right. And that's why a lot of the research now and some of the research that I'm doing is looking at this prehabilitation, right? Trying to focus on exercise and nutrition before and to see how the outcome can change, even if they are diagnosed, but how is that going to affect and impact their trajectory in treatment? So, and sometimes it is completely difficult to sort of prevent, but of course, those recommendations sort of apply to anyone, and it's something that we should all be thinking about. But definitely prehab is an area where we need to focus in, because sometimes we're screening people, but we're catching them so late down the line that we don't have an effect anymore. It's not, nutrition it won't be as beneficial. So targeting before in order so that if they are gonna go through treatment, they're prepared, their body is ready, and that they can have a better outcome. Yeah. So it is for prehab nutrition, again, it would be those recommendations, but then it would depend on what that individual is presenting with, right? Before undergoing the treatment, it may be that we have to sort of do a one-on-one consultation to sort of target and tailor that nutrition intervention. Some people may need to go on nutrition support before they get into treatment, and that will all depending on really the goals of care and the outcome and all of that stuff, yeah. Yeah.
Going back to the old, I guess it was Hippocrates, he said that let food be thy medicine.
Yeah.
With that in mind, are there any specific anti-inflammatory diets that you focus on with your patients?
So in terms of the anti-inflammatory part, unfortunately, the research is quite sparse in that area. But again, right, we're focusing on incorporating the plant-based foods because that's where you'll get your antioxidants from, like the fruits and the vegetables. But in terms of specific antioxidants, it's not. And as you've heard from Dr. Mack too, it's just not. The research is still quite limited in that. Yeah.
Great. Thank you so much.
Thanks.
Thank you so much.